Good afternoon, everyone. Welcome to Ethics for Lunch for November. My name is Mark Hughes. I co-chair the Johns Hopkins Hospital Ethics Committee. And as many of you know, Ethics for Lunch is our monthly session sponsored both by the Ethics Committee and the Berman Institute of Bioethics to talk about issues in clinical ethics. This is a CME event, so if you are interested in getting CME credit or continuing education credit, the code for this session is 43690. If you text that to 443-541-5052. Got a great panel today. Today's topic is going to be voluntary admission to child psychiatry. And the question, is it always voluntary? I'm going to turn the session over to Shannon Barnett to get us started.
Okay, good afternoon, everyone. Welcome again to Ethics for Lunch. We're going to be discussing child psychiatry admissions, and we will go over a little bit about what the process is for those of you that don't know it, kind of as we go through the case. But this is something that I've thought about a lot and wondered just about the ethics about. So we hope you enjoy the discussion. So the case, I'm sorry, I don't have them. Yeah, okay, thanks. All right, so this is a case about PC, who is a 15-year-old. Oh, this slide is, sorry. I don't know that slide, yeah, okay. PC is a 15-year-old with no prior mental health treatment. During an argument with his girlfriend, he threatened to kill himself, but continued to talk with her. Eventually they made up. He was no longer feeling suicidal. He went to school the next day, told some friends about the interaction, and a peer overheard him talking about feeling suicidal. There's a lot more education of high school students these days, and they're asked, if you hear somebody suicidal, please report it. So the peer did what he was taught and what we want him to do. Let one of the counselors know at school. The counselor came and talked with PC and his parents. And the counselor was nervous because he had been suicidal the day before and wanted him to go to the emergency room. Called the parents. The parents didn't think that it was necessary for him to go to the emergency room. The counselor decided to fill out an emergency petition so that the police would take him to the emergency room, and he was taken. And the way was the police are called to escort someone to the emergency room. They handcuffed the person, so he was let out of his school, seen by some peers, and taken to the emergency room. So I think we need to go back, yeah. So we have some questions. Yeah, sorry. For our panel, the first one is, why do you believe the counselor felt it was necessary for him to be evaluated in the emergency room? And maybe you can introduce yourself as you kind of talk about that. So anyone on the panel?
Hi, I'm Gloria, nurse on child, the inpatient unit, and work in the pediatric emergency room. Sometimes patients are, in the community, when people make these threats and these comments, people feel it's important to make sure that they get the treatment necessary. And since she felt that the parents weren't taking the necessary action, she felt it was her duty to make sure he at least had an evaluation by a professional.
Okay, thanks. Anybody else on the panel?
Yeah, I would just add, and I'm Nadia. I'm a child and adolescent psychiatrist who does a lot of work in the ER and on consults. And I would add that, because the potential risk for suicide is so high, and especially in kids, children and adolescents, it is like one of the leading causes of death in kids, we do take like any statements about suicidal ideation very seriously. And so I think, you know, if you hear about this happening, like I think the next kind of inclination is, okay, we need to get that person to a safe place so we can evaluate them more.
Okay. Anyone on the panel want to discuss ethical principles kind of as making the decision? So the parents have said they don't want their child to be taken to the emergency room, and the counselor at school is thinking about that. So what are kind of the ethical principles maybe to be considered while making a decision like that?
So I'll jump in now. My name is Simone Thompson. I'm a social worker and the associate director of the Hopkins Child Protection Team and a member of the ethics panel. I am often asked questions about concerns for neglect if a parent is choosing an option other than what is being recommended by a medical or mental health or behavioral health professional. And I think the important thing is to try to understand both the recommendation from the medical, or in this case, behavioral or mental health person, where that recommendation is coming from and based on what expertise. And for the parent, it's similar. What is their assessment of the situation and why are they choosing or advocating for something different? So the ethical principle would be both sort of respect for a family's ability to make decisions for itself, while also holding forth the primary importance of patient safety, or child safety in this instance.
Okay, thanks. Anybody else on the panel have anything to add? If not, I would like to hear what people think about the practice of handcuffing youth and before taking them to the emergency room.
I can jump in on this one. Hi, I'm Diane Pickett, social work supervisor in the pediatric emergency department, and also on the acute inpatient psychiatric hospitalization, the inpatient unit and the day hospital. You know, when kids are emergency petitioned to the ER, it can be a very traumatic experience. And so it's really hard to sort of weigh being brought in handcuffs. And also someone was really concerned about this kid and the statements that were overheard and how to make sure that we get a good evaluation for safety. In this particular situation, it sounds like when the patient was brought to the ER, he was calm. The statements had happened the day before. And so handcuffing him and being brought in by police can be incredibly traumatic for youth, especially if they're seen by their peers, and can also have long-standing effects as well, you know, including the evaluation, but also like being brought in by police, being brought in handcuffs. So that's a real challenge for these emergency petitions.
I think what's difficult, and I certainly agree with Diane about the consequences for kids, but an emergency petition is a form and a process that is completed when someone in the community believes that a child or an adult, but basically anybody, is at imminent risk of serious harm to themselves or to someone else. And our society does not allow for just anyone to scoop someone up and force them to go to the hospital for an evaluation. If I were to do that for somebody I was concerned about on the street, it would be considered kidnapping. So police are given a particular role in this instance to forcefully, if necessary, transport for the person's own best interest is the idea of what that is. And they are not mental health professionals, so are unable and would be inappropriate to try and assess what the degree of risk for that person is in that moment. And I fully agree that handcuffs are problematic in many, many ways, even for people that are thought to have committed a crime. But we're relying on a police officer to safely get a person from the community to the ER, particularly without their ability to elope or to engage in harmful behaviors to themselves or someone else. So if they're actively suicidal or homicidal and are in the back of a vehicle with the ability to escape that vehicle, can understand that it presents its own risk to the person that is being transported and also possibly to others around them. So I don't like handcuffs in any way, but I think that it's one of those things where it's the best worst option, I guess.
It looks like,
Yeah.
oh, go ahead, sorry.
I was just going to add, I think there's not, I don't know that there's much known about, are there safer ways to transport people and how would you make that decision? And I'm not sure that society is super invested in figuring that answer out to that question or thinking about it. I do know that I've had over the years, many patients complain about it and be fairly traumatized about it. So there's this, at the same time, I'm sure if I talked with the police officers who transport, they probably feel more comfortable with this. So I'm not sure that there's.
I would add to, like, in this particular scenario, had the parents, and I'm not sure that they fully understand that, but had the parents brought this patient in on their own, he would not have been brought in handcuffs. He would have been brought in by his parents willingly, treated as a patient, right? But because it went the emergency petition route, where the parents did not want to bring him in, the police were called and he was handcuffed.
I see we have a couple of audience members with their hands raised, so I might call on them to see if they have other things to add. Scott Walsh. Scott, I'm not sure if you are still there or if you might be muted. And while we're, oh, go ahead, Scott. Great. So Scott, it looks like you're able to talk now as long as you unmute yourself. And maybe while we're waiting to work out some technical difficulties, Hillary Heslop, if you, you're also available to talk if you can unmute yourself. Go ahead.
Actually, that was just an accident. I'm sorry.
That's okay. All right, why don't we, we're having trouble with unfortunately hearing Scott. So why don't we move along, and then if you are able to, oh, there you go. If you're able to unmute yourself, we're happy to hear your input as well. Okay, Shannon, I don't, so just moving to the next kind of part of the case, do you want to?
Sure. I think we have one more slide, next slide. Okay. So PC was brought to an emergency room outside of the Hopkins system. While there, he denied current suicidal ideation, but he did have significant symptoms of depression and anxiety. He was there with his parents. Neither him nor his parents wanted him to go in the hospital. And the clinician was worried that he was not being honest about the resolution of his suicidal thoughts, did not feel comfortable about letting him go home. But when that clinician voiced concerns to the parents, the parents continue to refuse a psychiatric admission. So here are just some options for the clinician in the emergency room that we kind of often think about. One is that the clinician could develop a safety plan with the youth and the family and discharge the youth to the family. If the parents are willing to sign, since this is a 15-year-old, his parents would sign him in for what we call a voluntary admission. And if the clinician believes the youth does not needs admission and the parents are refusing, we have a route called involuntary admission, which usually includes calling Child Protective Services, actually having Child Protective Services decide if they're going to take custody, and then if they do, doing an involuntary admission. It's just kind of the options. And then I was going to just go over this. This is just some information for everybody in the audience who's not very well aware. Maryland Medicaid, which is at least at Hopkins, a large percentage of people, and I think these are often for lots of other insurance. In order for an insurance company to pay for a psychiatric admission, the child must have a diagnosis that is expected to improve with treatment, and then they have to have one other criteria. One criteria is they must making dire threats to themselves that require 24-hour supervision. Another is threats towards other people, severe psychiatric symptoms that can't be safely treated as an outpatient, or the last option is they need something that isn't available, maybe ECT therapy. So for this youth, I think the criteria for admission was that he was making a dire, that there was, the clinician was concerned that there was a threat to his life. And that is what was used both for kind of making the decision that he needed an admission, and then also to make the decision of whether to kind of go above the parents' decision making. So in Maryland, if parents refuse treatment, then the person in the emergency room can kind of look at criteria for medical neglect. And if those are met, the clinician can call Child Protective Services. When a parent refuses the admission, the clinician can inform parents that the threshold for medical neglect, if it's been met, and the parents don't agree with the psychiatric admission, then the clinician will call Child Protective Services. So this is probably, in my experience, one of the most common things. So the parent refuses, and the clinician in the emergency room says to the parent, well, if you are refusing, then this is meeting criteria for medical neglect, and I'm going to have to report you to Child Protective Services. And Child Protective Services, if they're called, they have the power to investigate, and if they think it's necessary, they can take custody of the youth. And if they do so, then the youth is actually in Maryland, the youth would still be involuntarily admitted, but be under the custody, temporary custody of the state. But what frequently happens is when parents learn that they cannot stop a psychiatric admission, they often sign the voluntary admission form to keep the state from taking custody of the youth.
Shannon, can I offer a clarifying point? It's
Sure.
Minutia, but it's not really. So when I would change in the first sentence that if parents refuse treatment and the threshold for medical neglect has been met, then the clinician is required by state regulation and law, actually, to call Child Protective Services. So if we're concerned for maltreatment, including medical neglect, or in this case, I guess we would include behavioral health as medical neglect, then we, as medical providers or those affiliated with a medical institution, are required to make a report. The other thing that I would clarify is that if the agency takes custody of a child, so when I say the agency, I mean CPS or its parent agency, the Department of Social Services, that does not automatically allow the agency to sign any sort of medical consent for a child in their care. In order to get anything beyond routine medical care, and inpatient hospitalization is certainly not routine medical care, they have to petition the court for expanded medical decision-making authority. So I point that out just to say that we sometimes relay to parents or to others a shorthand. Oh, well, if CPS is called, then they'll be, they'll get the kid signed in. And that's a shorthand for a very particular legal process that's not as straightforward as we sometimes present it.
Yeah, I would agree with that. I think, and in Maryland, very rarely does the court allow the state
Agreed.
to sign people in, which is why almost youth who are in foster care are usually involuntarily admitted unless there's a parent that has co-guardianship that can sign them in. So, okay. So I also wanted to go over just the threshold for medical neglect, which is called the harm principle. And the harm principle is states that in order for it to be medical neglect, there's a high likelihood of imminent death or serious permanent physical damage without intervention. The proposed intervention has a good chance of success. The expected side effects of the intervention are not as severe as what would be expected if the child does not undergo treatment, and there's no acceptable treatment alternatives to which the parent would agree. So all these criteria are supposed to be in place in order for there to be a finding of medical neglect to the point that the state would take custody. So we have more questions for the panel. So I think my first question, the first question of the panel is, if you were the clinician in the emergency room, how would you decide whether or not this youth required psychiatric admission?
And Shannon, I want to point out, this kind of mirrors a question that came from one of the participants, and that why did the parents refuse care? And I clarified that it didn't seem that they had refused care, but they did not agree with admission. And so this may help to highlight a response to that question.
I think that the parents also wanted to do something different. They wanted to start with something outpatient, and after meeting with their child, felt that he was safe to come home and that they could keep him safe. Is that correct?
Yeah, yes, that is actually what happened in this particular case. And I think that there's often a disagreement. Parents often think they can keep their kids safe. And the clinicians, sometimes they agree with that and sometimes they don't. So it could be interested to hear what other people on the panel, especially people who've worked in the emergency room, think.
This is Diane. I think there are several reasons that a family might refuse. It could be cultural. It could be they don't believe in mental health services. It could be that this is the first that they're hearing of it and they want to try something else. So I think there are many reasons that families don't want an inpatient admission. Maybe they've had some experience in their family that negatively impacted someone from someone else having an inpatient admission. Admitting a patient psychiatrically is not a decision that is taken lightly by any clinician in the emergency room. And the pros of the safety need to outweigh the discharge, right? And so that is a constant conversation in any clinician's head as to why that recommendation would be made.
I tend to think as well about a couple of factors that families may or may not be aware of. But when I worked in the community prior to working in this setting, and very first accompanied a child who was being admitted involuntarily, and she was young, she was 8 or 9. And I was a social worker in the community at that time. Having a door lock behind you as kids are being restrained or placed in seclusion nearby, as an adult who understood what was going on, I was still honestly rather traumatized and remember it quite clearly. And so again, to sort of mirror what Diane said, it's the importance of 24-hour constant availability of staff for supervision and support, that immediate crisis need versus the possible, not definitive, but possible negatives of the trauma of separation from family, and being in a situation where other children nearby are in crisis. And there in some venues is still a stigma against people that have had inpatient psychiatric care. So.
Okay. Now, I want to hear what people think about whether the youth meets criteria for admission and whether, and maybe the same kind of at the same time, talk about whether they meet the threshold for medical neglect if the parents refuse admission.
I think this question also came up kind of tangentially in the chat too, questions about like, what are the criteria, or like, does this youth meet criteria for involuntary admission? And I think that's a great question, and maybe something that varies based on experience and approach in the emergency room. I think that when I'm like making decisions about a patient, whether or not they need to be admitted, I'm thinking very much about kind of what are acute thing, or like, things that have changed recently in this person's like situation or life that we could actually like intervene on with an inpatient admission, and what are the things that we can do in the community or with the family to help protect this patient, because the fact is that even if we do admit somebody, it's usually for 5 to 7 days, and then they're back in the community. So what our goal really is can we make somebody safe in the community? And so I think that leads to me having a generally pretty high threshold for admission, because I want to make sure that we have kind of a goal for that admission, and that we can't reasonably keep somebody safe with a lower level of care. And just to answer, David had another kind of piece of the question, which is like tangentially related, but are there like crisis services in the community? And it depends a lot. There are, but it depends on things like insurance, what city or county you're in. And so I'm not actually sure if this case that we're referring to, there was access to kind of a crisis intervention team. But in Baltimore City, for some kids, we do actually have a team that can is like funded through Catholic Charities and can go out and assess patients or can provide next day care. And we make that referral a lot from the emergency room too.
One of the things, sorry, one of the things that was raised during preliminary discussion, I think that, again, this is, I'm actually repeating other people's, but that the assessment in our ER can seem very, very different than what happened either at school or in this instance, it was school, but wherever the youth is at the time of the emergency petition. And it's easy for us as providers here who see these kids or kids with these sorts of concerns many, many times every day, that our threshold for concern is different perhaps than it is in the community or even in different ERs. And by the time the youth gets here, they may also be presenting quite differently than they were several hours before when the emergency petition was being completed. So I was reminded of the importance of grace and mutual understanding with community providers who may have very different experiences and thresholds and are also facing the patient or youth at a different point in the clinical timeline.
I had a question just particularly about the medical neglect, because I think the medical neglect says like there's a high likelihood of imminent death. So just wonder if people feel like that threshold was met in this case, and if that seems to be the threshold in general for involuntary admissions.
I don't know if anybody of the attendees have their own reflections or thoughts or experiences with this. I know that I've had quite a few philosophical conversations about what does imminent risk mean, and what is a possible dire consequence. And they are really subjective terms that aren't outlined in an objective way that can be measured. And so typically screeners at, so each jurisdiction is responsible for the children that live within that jurisdiction. So every county in Maryland and Baltimore City, if you call the Baltimore City CPS screening line, they often are looking for something that helps them to understand what that imminent risk means. And typically it will be something along the lines of, if this child leaves, could they die? It's that level of seriousness. And sometimes people express frustration that it would have to be that extreme. And the way that I think about it is sort of the opposite of that, which is, well, but would we want something that is relatively mundane to mean that police can pick you up and force you to go somewhere? And so that again tends to be the requirement that they're looking for.
Yeah. Okay, so one of the things I think about, like, you know, suicidal ideation actually has, it's a risk factor. So we, like Nadia said at the beginning, we want to, you know, suicide is one of the leading causes of death in this age group. So we want to prevent it when at all possible. At the same time, we're horrible at predicting. And I'm not sure that the evidence is clear that risk of that happening after discharge from emergency room versus after discharge of an inpatient hospitalization is different. And so kind of if you take those into the mix, I think that does add something, but I also think the threshold for kind of involuntary admission and for calling CPS really seems to be just the clinician is worried. And it is hard because we don't know the numbers and we're not very good at predicting. I don't know if anybody else has anything else they want to say about that.
I mean, I think when making this decision, whether to involuntarily certify a patient against a parent's wishes, there has to be an imminent risk to self or others. And you know, they have to have very few protective factors. They have to have a means usually when they go home. And so maybe they've had previous suicide attempts and not disclosed it to anyone in the past. Maybe they told the clinician that they were going to go home and take a bottle of Tylenol and then wouldn't disclose that to the family. Maybe something else came out in the assessment that they cannot disclose to the family. maybe they're saying that there's a gun in the home, but they can't say it because dad's an officer. I mean, but the risk, the imminent risk to involuntarily certify someone has to be immediate and very high. Most times CPS will call the family when the call is made from an emergency room and talk through sort of the options. And then the family will agree to the inpatient admission, which is also, I guess, another ethical question, because that feels like coercion to families.
I think we'd have to know, there's other things that we haven't talked about, such as did the social worker or the person interviewing the patient and the family, like what was the family's reason for not doing the admission? What were their alternative plans? Were they able to come up with a safety plan? And like Diane said, did this patient have a plan and a means to do that? And we don't have those answers right here, but I think that those are other options and things that we need to take into account.
So I think we can continue on with the case. I guess one more comment I wanted to make before we move on is just this question of what are the risks of an involuntary admission, and just having thought about this a lot, moving from adult psychiatry like training to child psychiatry training. I think that when we as psychiatrists or mental health professionals are kind of imposing treatment that's not wanted upon a patient, I think the risks are significantly higher if we're doing that as their first contact to like mental health treatment, because I think that can really change somebody's willingness to kind of engage with care, not just immediately in the short term, but also kind of throughout their life and their trust of, you know, mental health professionals and that sort of thing. So I think about that a lot when we have these cases that come in and we're trying to weigh the risks and benefits. But yeah, let's move on and talk about, just in the interest of time, and what happened next.
So the clinician in the emergency room continued to remain uncomfortable letting PC go home. I think, you know, just mostly like not knowing that they didn't want an admission and just not trusting PC when PC said that he wasn't suicidal anymore. So the clinician told the parents that if they don't sign the medical, that they don't sign the voluntary, she call Child Protective Services, make a report for medical neglect. And so the parents reluctantly signed the form. And then Johns Hopkins had a bed, so he was transferred to our inpatient unit. When that happens, it goes directly from their emergency room to our inpatient unit. And as soon as they got onto our inpatient unit, the family immediately requested discharge. I think I have some questions. So one is, I think we've kind of talked about the ethical principles about calling. I guess, you know, I think one question is, you know, the threshold to threaten to call Child Protective Services may be different than the threshold for Child Protective Services to take custody, but parents also don't know that. And it's particularly scary to have Child Protective Services threatened. Parents are worried about not only the child in the emergency room, but their other children. Also, parents who work with kids, you know, Child Protective Services being called can cause problems sometimes with people's jobs. So I guess that was one of the questions is there, okay, kind of ask the panel thoughts about just that threat and making that threat of calling Child Protective Services. What people think ethically.
So I I was trying to hang back because I've been so chatty during this, but partly because of my role. Again, I work with the child protection team for the hospital, and we're consulted when there's concern for maltreatment as a reason that a child is presenting or a youth is presenting for care to the ER or has been admitted. So this is the work that I do every day. And I recognize that calling CPS is not a no risk situation. And so, you know, we are obligated to provide good care for children and families. And we're required by law to make reports when we are concerned for the possibility of abuse or neglect. And then I remind providers that we also have our own training and expertise in assessing situations for safety. And I think that it's important to utilize colleagues and to understand our own experience and, again, expertise, not to avoid calling CPS, but to be mindful of the reason that we are calling and to provide as comprehensive contextual understanding to the agency as possible when we do make a report. But when we call CPS, it has its own possibilities for consequences that we don't anticipate, be that, well, we only wanted them to be involved to do an assessment. I didn't know that the child would be removed. Well, why are they removing all of the siblings? And then understanding that actually removal doesn't mean that a child will remain out of the parent's care. There's a lot of complicated aspects to it. And so I think sometimes I'm perceived as downplaying people's responsibilities to call when they state a concern because I ask so many questions, but it's because I want people to not do it only as a default. Well, I thought about abuse, so I need to make a report. But to be mindful of what is it that is making you concerned? What is your degree of concern? And how does that match what the requirements are? I had a colleague who was at AAP, I think, conference recently, and she said one of the presentations talked about the need for mandated supporting, not just mandated reporting. And of course, the regulations are for mandated reporting, and I understand that. But I thought that it was an interesting conceptual point that we often default to reporting people when we think they're not doing what they need to do, without thinking about what we can do to help them do the things they need to do.
Yep. And I guess the next question I have is like, do you feel clinicians in the emergency room routinely apply that harm principle and those criteria? I think as somebody who, so I came for child psychiatrists, we all do our adult training first, and we learn the voluntary versus involuntary criteria, and involuntary is danger to self or others. And that's not, I think it's not, probably doesn't have maybe as high a threshold as when if you really read the harm principle, the threshold for calling medical neglect. But until I got into ethics, I've been a child psychiatrist for years and didn't even really know what these criteria were for calling, calling child protective services for medical neglect. And I believe a lot of clinicians in the emergency room are just saying is this child is a danger to themselves, and just kind of using that one criteria. And so I guess, so one of the questions I had when I kind of thinking about this is, should our clinicians in the emergency room be applying the harm principle, which is all those criteria? So really imminent risk of death, requires inpatient hospitalization or requires the treatment. There's nothing else available that the family is agreeing to that might also be reasonable. I don't think I was ever trained in that model of thinking. I wanted to hear what other people thought.
I mean, I can say in our own emergency room, the social work does the initial assessment. But we work as part of a team. So there is also a resident and there is an attending and there is a psychiatric nurse. And all of these different team members are evaluating this patient and hopefully the least restrictive environment that will meet the patient's safety needs. In our emergency room, if the parents are refusing the admission and the team feels very strongly that an admission is necessary, we then have access to a consult team, which would include a child psychiatrist to come in and also evaluate the patient and do an additional sort of safety risk assessment. And then if all of those team members believe that this youth cannot be safe outside of the hospital, then we would have a discussion with the family to say, you know, we cannot come up with a safe discharge plan, and we are strongly recommending the inpatient admission. And if they continue to refuse, we would then say, well, you know, we are then going to call Child Protective Services because we are so worried about the safety of your child. And hopefully during those discussions, we can come up with a resolution that doesn't result in the CPS call. I mean, it's a very thorough assessment in the emergency room. So I do not think that this happens frequently. And when it does happen, it is really the only option.
I think that is the case in our emergency room, Diane, because I know that we have all of those steps. But I've seen many kids come inpatient and the parents immediately went in to put in a 72-hour notice to take their child home, and said they were told that if they did not sign the voluntary, that they would be admitted involuntarily.
Right.
And CPS would be called. And I think that that is a common practice in the community, even if it's not in our hospital.
Yeah,
A lot
and
of
my guess,
harm can come from inpatient. You know, they're exposed to many different types of patients while they're here. Relationships with patients that have maybe behaviors that you don't want your child to be exposed to and take home. There are aggressive events on an inpatient unit, and coming inpatient should not be taken lightly either.
right, yeah, I think that there is, and you know, I think like Diane said, at Hopkins, there's multi-layers and a lot of different people thinking about it. And I think there is a lot of work to try and come up with a safety plan. And I guess, you know, that question is, you know, and this isn't something that as Hopkins we can necessarily do anything about, but just kind of from an ethics point of view, you know, would it be nice if other places were actually had the training? Again, I don't think I had the training on kind of what the harm principle was before this. So I think one of the things that this case just bring up, and this is kind of more of a legal question than ethics, but can the Hopkins inpatient unit refuse to admit a youth if there are concerns that the youth did not meet criteria for admission criteria is what's missing on the slide. And I think the next slide actually has.
We cannot refuse a patient, even if we think that they do not need admission. There's an EMTALA law, and if a clinician did evaluate the patient and feels that they need to be admitted, and if we have a bed available and the capacity to treat that patient, we must accept them whether we think they need admission or not.
Right, and so this is a legal mandate that we do. So it's not up to our team to decide whether or not we agree that the youth requires an admission or not. So when this case, most likely what happened was somebody called, said we have a 15-year-old in our emergency room, brought in for suicidal ideation, and his parents signed the voluntary. So there's not often a huge discussion of how, if the kid's currently suicidal versus just was suicidal during an argument. And also, I think Gloria can kind of answer this more. I don't think there's the parents only sign the voluntary because we threatened to call Child Protective Services versus the parents signed a voluntary. So I think a lot of times that it's found out once the youth gets on the floor.
That is correct. We don't get that information.
So, so I think a couple questions for just this happens are when a youth comes to the unit, we can go to the next slide. How should the inpatient team respond to parents' request for discharge? And then kind of once the situation happens on the inpatient unit, kind of what are the goals of the admission?
I think I saw that in the chat box that there's a question from one of the attendees. Did someone else have a question?
Yeah, there's a couple questions. One was asking, do we ever get ethics consultation in these cases? Yeah, I don't know if other people have experience with consulting ethics.
We get ethics consults on our inpatient unit, from our inpatient unit sometimes. I've not seen them from the emergency room, and it's not usually about this topic, but they are related to other things about, keeping a patient that may want to leave, or just different situations that may be going on with the patient or the family, but not about this particular, but we do use the ethics consults.
Yeah. I think that sometimes there's ethics consults when there's a disagreement between the family and the team, and if the team's thinking about overruling the family, but I don't know that I've ever seen that in the emergency room.
I have not had the experience of ethics consult in the emergency room.
I don't recall having either.
Yeah, nor have I. I think that some of the cases where we wonder about this, though, we do consult them later in the course of their treatment if they're on the inpatient unit.
Mm-hmm.
It brings up to me, as a role of the nurse in the emergency room, if you see this happening, is that something that we think the nurse or any other provider should do, is reach out and ask for an ethics consult?
Yeah, I think it's a reasonable thing for us to be considering. I think in the emergency room, because of the pace, it's not often something that even will pop into people's minds. Like maybe an ethics consultation would be helpful, but there may be cases where it is.
Yeah, I'm thinking of it. There have been times when the outpatient team, so a youth who's really well known to an outpatient team, is in the emergency room, not like they're no longer suicidal. And I can remember a case where the peds team, and I think even I went and saw the youth, felt okay with the youth going home, but we had a lot of pressure from the outpatient team saying that they didn't feel that they knew this youth significantly better than I did, just meeting them in the emergency room. That might have been a really good time to have an ethics consult, because there was a lot of issues where we were, in that case, the pressure to admit was actually coming from an outpatient team that did know the youth pretty well. But the parent and the pediatrician were all pretty uncomfortable, or didn't think, or the parent didn't want admission and the pediatrician didn't feel like it met that threshold for involuntary. That might have been a very good time for an ethics consult.
There are a couple of questions that are coming up about kind of, I guess I'll just read them. So isn't the real issue here whether coercion is appropriate in this case? And then kind of ties into another question that says, or that's wondering kind of, are there other ways to consider working with families in this situation where we don't kind of jump to the potential coercion of saying, you know, we need to call CPS. Can we engage them in care in another way that's more collaborative? And I actually think that may tie in a little bit with how our next questions here for the panelists, which we don't have a ton of time for, but maybe one or two comments on what are the goals of an admission in this case if the patient, if the parents are requesting discharge. I know.
I can tell you how we have responded in the past, because I have seen it many times. There have been times that when the patient comes in and requests, the resident and the attending do a good evaluation on the patient and determine that the patient is safe to leave, and they would discharged the patient immediately. I have also seen times where it's been nighttime and we've asked the parents, can we, let's just get your child here safe for the night. In the morning, have the full team do a thorough evaluation and then determine if he can leave. And next morning, we have done that evaluation and the parents with their agreement and discharge the child. And then sometimes we have said we need the 72 hours to assess the child, because we really also agree that that child's not safe to leave, still suicidal or high risk. So we would take that 72 hours and then either at the end of the 72 hours we've discharged, or the parents have said, you know what, I see the value. Let's continue on with his treatment there. So I've seen all kinds of scenarios. It's really dependent on that particular case.
And I can just give like a follow-up on this particular case. The parents did actually, they requested discharge immediately, but then they did agree that since he was already on the unit and he did have social phobia and depression, they agreed to start him on a antidepressant. And he actually agreed to outpatient treatment with the Hopkins attending. And so probably stayed 4 or 5 days. This is a case from several years ago, but followed up in my clinic, continued to complain about recurrent intrusive thoughts and nightmares about being handcuffed in front of his peers at school, and as well as the inpatient unit. And just a few months later, even though he had some benefit from the antidepressant, dropped out of treatment. So I think this case kind of just demonstrates that there were some kind of lasting impacts, some lasting trauma symptoms from the involuntary part of the admission. And I don't know whether or not, it's hard to tell, but if he would have dropped out of treatment, if he had just been referred to outpatient and not actually had an inpatient unit. It's hard to know that. So it is 1 o'clock. So I don't know if anybody has any last second things they want to say.
I would just add that I feel like as we were kind of prepping this case and discussing it both this hour and previously, that there are so many different kind of ethical questions that come up along the way, and legal questions about kind of how do we approach these situations. And so I think this could have, taken a lot of different just like theoretical discussion turns. And it's really just been, I want to thank our panelists for coming and for taking the time to help think through this case and how we approach these things practically, but also like what are the things that we consider when we're making these tough decisions, and we're trying to partner with families that have maybe differing opinions about what might be best for their kid, and how we do how we approach those situations.
I do appreciate the question about the coercion, because I do think that that's kind of the crust of this case is when is it ever ethically permissible to use coercion, and when is it? And again, I'm not sure that we answered that, but kind of at least talked about some of the different thresholds and why people might think about that. So I appreciate that question, and I appreciate all the panelists as well. All right.
All right.
Thanks so much
Thank
for everyone for joining, and particularly for those of you that asked questions.
Thanks.
Thank you.